Hello everyone, I'm Ruba Bayram, currently a second year medical student, and today I will be explaining the chronic obstructive pulmonary disease or COPD, the pathophysiology of it mainly. In this video, I'll be talking about the anatomy and function of the respiratory system in general. Then we'll look at emphysema, chronic bronchitis, which together they form the COPD, and then we'll look at other obstructive disorders such as asthma, bronchiectasis, and atelectasis. So, in the anatomy, I just wanted to discuss a specific terminology that we will deem useful later on in one of the things, one of the definitions of the obstructive disorders. But generally, the respiratory system consists of the trachea, and the trachea starts to bifurcate into primary bronchi, and then to the secondary bronchus, the tertiary, and it continues until it reaches the terminal bronchioles. Distal to the terminal bronchioles here, distal to it, so after it, we will have other structures. These structures are known, this region that is distal to the terminal bronchiole is known as the acinus. This involves the respiratory bronchioles, the alveolar ducts, the alveolar sac, the alveoli itself. Okay, so my important point here that I wanted to mention is my acinus. Acinus, it is the region that is distal to my terminal bronchiole. So all this region, and this involves which structures? The respiratory bronchioles, the alveolar ducts, the alveoli sacs, and the alveoli itself. What is the function of my respiratory system? We have two different functions mainly. We have the ventilation, which is defined as the movement of air in and out of the lungs, whereas perfusion is the actual exchange of gases that is happening between my alveoli as well as my capillary pulmonary capillaries, so the blood. So here in perfusion, it is this area specifically between the alveolar wall and then the capillary. In the ventilation, it is the movement, the whole movement of the air. It's just the mechanical movement, the breathing, you could say, of the air inside of the lungs. Now, if I have any failure in any of these functions, there's different manifestations that might occur. For instance, if let's come to the ventilation, if there's a problem in this function, there could be hypoventilation or hyperventilation. In our case, I'll be discussing hypoventilation, where the movement of the air is very slow and very shallow. What happens? Imagine you are a person and you are trying to blow in blow inside of this balloon. The balloon in this case is our lungs or our alveoli, tamam? And here what we are seeing is because your ventilation or because the movement of the air, we're talking about hypoventilation here, because of the movement in hypo, it means low. So the movement of the air in and out of the lungs is very low. So you're either breathing very slowly or inside of this lungs or the balloon, or you're pushing through very short puffs of air. So this will take time. And the idea here is that because the movement of air is very slow, less oxygen will be reaching the lungs, or the let's say this balloon, less. Okay, so that's why you see hypoxia in hypoventilation. So the amount of oxygen inside of the blood is low because of the slow breathing, of the slow movement of the air inside of this balloon. So here what has been impaired? The movement of air in, tamam? But also the movement of the air out is also impaired. What needs to be moving outside of the lungs? The carbon dioxide, right? The carbon dioxide leaves or tries to leave, you try to expire carbon dioxide out. But since the movement, the general mechanical movement of the air, both in and outside, is a problem, so now the carbon dioxide won't be able to leave as properly, and therefore the carbon dioxide will start to accumulate inside of the lungs, and therefore will start to accumulate inside of my blood. That's why we have hypercapnia, tamam? Because the problem is in breathing. You have shallow or very slow breathing because the movement of the air is impaired. Movement of the air both in and out is both impaired. So if movement of the air in is impaired, there is less oxygen that is getting in, and because there is a difficulty in pushing pushing out or movement of air out, there's carbon dioxide won't be able to leave and therefore starts to accumulate. Why is that a problem? Because in hypercapnia, whereas it is the increase of the carbon dioxide concentration in the blood, this in turn will depress my respiratory center. The respiratory center is there in order to recognize if there's any changes inside of the concentration of gases in our blood, and tries to adopt different methods in order to counteract this. For instance, if I have hypoxia, there's many different ways the respiratory system or center will recognize that I have low amount of oxygen in my blood. It will try to tell different systems to perform differently, or maybe it will try to increase your own breathing, right? But in this case, since I have hypercapnia, this will be depressed. So now the respiratory center won't even realize that there's any changes and won't be able to do anything about it. So in these patients with hypoventilation, you won't see that there's any dyspnea or any difficulty breathing, or they're trying to breathe much faster. No, there is no such thing in these patients, okay? Because of the hypercapnia. We talked about the ventilation if there's a problem. If there's a problem in perfusion, it is called as impaired diffusion. The perfusion we mentioned is the exchange of the gases across this area. So sometimes there's impaired diffusion that occurs. The diffusion is highly dependent on diffusion rates. The diffusion rate is important because it depends on the surface area of the alveoli, the wall of the alveoli or of the system, respiratory system, صح? And also on the concentration of the gases itself, like if we have a concentration gradient and all of these things. So there's many different reasons why there could be impaired diffusion. But the idea is, if the diffusion is impaired, the problem isn't with the movement of air. The air can move in and out very easily. But the problem is, how will it move? The diffusion. Generally, oxygen needs to get inside and carbon dioxide needs to leave. So this is very important in diffusion rates we're talking about. It's dependent on either the gases we mentioned or this area, the alveoli. So in these patients, the oxygen won't be able to diffuse as easily because there's an impairment in diffusion. It won't be able to get inside, so therefore you will see hypoxia, low amount of oxygen. But why will I see normal capnia or normal concentrations of carbon dioxide? Is because carbon dioxide as a gas, it is a characteristic or property matter, it is that it is greater or has a faster diffusion rate, or it is much easier to diffuse. So therefore, even if there is any damage or any impairment in the diffusion, the carbon dioxide will still have the ability to diffuse much more and much better than the oxygen. Okay? Okay, hopefully this makes sense now. Now, to talk about the difference between obstructive and restrictive disorders, I will touch on it very briefly, just to understand. In obstructive disorders, the problem is in expiration, meaning that there's something obstructing. You can get in air normally, because taking in air or inspirating, it's it's an active process. فخلص عادي air will come in العفو. Okay? But the problem is in expiration. When I try to expirate this air, since it's a passive process, this obstruction will prevent it from fully leaving, and some air will end up getting trapped. So this is very important to understand. So here there is reduction in airflow, there is a problem in exhalation of air, and so the air will remain inside of the lung. Okay? And restrictive disorders is the opposite. The problem isn't in expiration, no, the problem is in inspiration. From the name, it is restrictive. The lungs, my lungs here, they are very stiff, and so they won't have the ability to expand properly. If they can't expand properly, they won't be able to take in as much oxygen or as much air, so they can't get enough air, okay? Therefore, the problem is in inspiration. So there's difficulty in taking air in, and it is because of stiffness. So I just wanted to understand, our topic right now is obstructive. Emphysema, the definition of it is purely structural. It's a chronic lung disease characterized by abnormal irreversible, so COPD, all of it is irreversible damage. Permanent dilatation of the air spaces distal to the terminal bronchiole, wall destruction will happen, but no fibrosis. How do I learn the emphysema definition? Is through the 3Ds. 3Ds, so the first D is my dilatation or dilation of my air spaces. Where are the dilation happening? In the region that is distal to my terminal bronchioles. And there is wall destruction of the alveoli, but no fibrosis, no healing. Tamam? So dilation of the air spaces, number one. Distal to the terminal bronchiole. What was the other name to the region that is distal to the terminal bronchiole? It was the acinus, remember? That's what we explained in the anatomy. And there is wall destruction. but no fibrosis. Now, why this dilation of the air spaces is happening? The dilation of the air spaces is happening because of wall destruction. Like, why is the wall destroyed? Generally, let's say this is my alveoli or my lung, whatever. The alveoli it is elastic in nature. It has elastin, a substance known as elastin, which provides this elasticity. Okay? If there is some sort of, and this elasticity is allowing the alveoli or the lung in general to expand, and then expand to fill in with the air, and then recoil to push the air out. If there is damage to the wall, the elasticity or this elastin will be destroyed. So here what I'm having is that my elastin is destroyed. If the elastin is destroyed, my recoiling ability is gone. So therefore, this alveoli will be filled with air, dilates, and it won't be able to push the air out properly because it lost its elasticity, because the elastin has been destroyed. That's why it will continue to dilate, because there is no recoiling ability, because I destroyed the elastin. So that's why with wall destruction there is dilation. Why? Because the elastin had been destroyed. What destroys the elastin? We will look into it. Tamam? Now, the types of emphysema. Emphysema can be divided based on where the dilation of the air spaces is happening. We mentioned, yes, it is in the sinus, but sinus, it was a whole region that involved the respiratory bronchioles, alveolar sacs, and ducts, and the alveoli itself, and all of these things, right? So it depends on where is the dilation happening, in which region of the sinus we can divide the emphysema. The first one is centri-acinar. Acinar, the sinus region, centri, so it is the central region of the sinus. We know this is the terminal bronchiole, and then we have distal to the terminal bronchiole, we have respiratory bronchioles. I'm just going to name it الصراحة, I'm not going to draw it. And then we have the alveoli, whatever. So the central part is my respiratory bronchiole. So what is being affected in centri-acinar? Respiratory bronchioles. Very important. Respiratory bronchioles are affected. What is the cause? What is the cause of what? What is the cause of the damage of the wall? What is the cause of the destruction of my elastin? In this case, it is cigarette smoking. So you can learn it as this. C, centri-acinar starts with a C. C as in cigarette. Smoking, so the smoke, think about it, there's smoke fumes that are going to be going upwards, and therefore the most area that is going to be affected, the more likely region that is affected is the upper lobe. We know there's many different lobes in the area, so the upper lobe will be affected because of smoking fumes, they go upwards. That's just one way you can learn it. So the upper lobes will be affected. Cigarette smoking is the cause. How is smoking going to be destroying elastin? Smoking, the cigarette smoke, the smoke in itself is an irritant. And this irritant, it's going to be causing irritation to the walls. It will cause the inflammation, right? With the irritation, there is inflammation. Inflammation, there's cytokines released. There's inflammatory cells that can be formed as well. We have all types of inflammatory cells, CD8, CD4, everything. Okay? So all of this are then the cytokines, and all of these will start to attack, and generally over time they will destroy the elastin, and this is going to be causing destruction of the walls because of the smoking, because it's an irritant, it destroys the wall. When the wall is destroyed, there is dilation that can happen. افتهمنا? So this was my centri-acinar. We come to my pan-acinar. Pan meaning that there is the entire thing or all. So here what we're saying is that the whole acinus region is going to be, the whole acinus region is going to be affected. This is the pan-acinar. What is the cause? So this is the entire. What is the cause of the damage to the elastin? Is alpha-1 antitrypsin deficiency. Let's discuss alpha-1 antitrypsin deficiency. The story starts with my neutrophils. Neutrophils, they destroy, a lot of infectious organisms, mainly bacteria, and they do this by many different ways, but one way is by releasing something known as elastase. Ase, meaning it's an enzyme. Elast, so it's an enzyme that is degrading elastin. So this neutrophil will release this elastase, and it destroys the bacteria, and it gets rid of it. The problem is, generally, this elastase, it is in normal amounts, okay? And we have something that is counteracting this elastase that is produced by the liver, known as the alpha-1 antitrypsin. So in our body, generally, I'm supposed to have a balance between this is a protease, it's an enzyme, protease enzyme. Generally, we have a balance between the protease and the anti-protease, the thing that is basically managing how it is a protective. It is protecting us from excessive effect of my protease. So there is a balance. If there is a balance, then both of them will be, they're working in normal amounts. Okay? So the elastase here, when it wants to destroy the elastin, it will destroy it in normal amount. But if there is a problem where the elastase had increased, now what ends up happening, it will start to this is a lung يعني suppose it will start to destroy the elastin that is found in my own lungs. That's the problem. But thankfully we have this alpha antitrypsin that is formed by the liver that is going to be controlling the effect of the elastase and inhibiting it if it goes way over the limit. Unfortunately, in the case of my pan-acinar, what happens is that there's a deficiency. There's a deficiency in this anti-protease. So now there is nothing that is stopping the elastase from working or kind of managing it or balancing it. So now elastase will end up actually breaking down the elastin that is in my lung. And therefore, lost elasticity, lost recoiling, there is wall destruction, now there is dilation of my air spaces. افتهمنا? So in these patients we will see that there's liver manifestations actually, and alongside the lung problems, and it is mostly going to be affecting the lower lobes of my lungs. I learn it as because the liver is lower or below the lungs, so therefore it is going to be affecting the lower lobes. That's the way I learned it. Whereas the upper, we said it is the smoking fumes that go upwards, and this was related to that. Okay, we understood the idea of alpha-1 antitrypsin deficiency. So generally, I need to have a balance between my protease and my anti-protease. But in the case of my alpha-anti-1 deficiency, this had decreased. And so more protease, more action of my elastase. The elastase is working more. Now it will destroy the elastin in my lungs, which is the whole idea. The elastin had been destroyed. In paraseptal, para means around. Okay, and it is mostly what is being affected are the alveoli or the acinus that is around the pleura of the lungs, which are the closest to the okay, so the acinus that is the most distal is going to be affected. What is the cause of the wall destruction or damage to the elastin? Well, it is idiopathic. There is unknown cause. There is not a specific cause. We don't know. In these patients, it is very dangerous because there's a complication that might occur. Imagine I'm going to be having continuous dilation. Until what point it ruptures. When it ruptures, air will start, and this is the pleura surrounding it. When it ruptures, the air will start to seep through the pleura. Right? And if there is air in the pleura, what do we call this? We call this pneumothorax. Right? We call this pneumothorax. But pneumothorax, generally, it is caused by trauma, like a stab to the wound, which causes, for a stab in the chest, for example, it causes air to get inside. But in this case, there is no damage, there is no trauma. It is spontaneous. But one of the if you need to know these terminologies, you need to know them, because in the questions, when you see them, you will be able to understand. I'm explaining each terminology so that it will be much easier to understand and notice. So in spontaneous pneumothorax, it can be one of the causes of death in patients with emphysema. Specifically, we're talking about the paraseptal or distal acinus. Okay? It's mostly going to be affecting distal and mostly the upper lobes. It is usually idiopathic. Tamam? So spontaneous pneumothorax, we understood it because it ruptures and then it causes it. Okay. I think I'm done. Morphology, the growth, what we can see with the eyes. Obviously, the upper 2/3 of the lungs are extremely dilated. We will see bullae. Bullae are basically dilated air spaces that are more than 1 centimeter. That's just the description. And they are very enlarged lungs. That's the morphology and growth. You can see with the eyes. Microscopically, obviously, you will see large alveoli, and they're separated by thin septa. This is very important. These words right here, these ones are the key words. Okay. And this is, I took them from the Robbins book. Okay, so this is my source of information. Yes, sorry, abnormally large alveoli, and there's thin septa. The thin septa, because of the destruction of the wall and the elastin, it has been destroyed. Therefore, obviously, this is the high, and the capillary surrounding it will also diminish. The capillary surrounding it will also start to diminish, and very important, there is no fibrosis. So, if I say what is emphysema, the 3Ds, dilatation or dilation of the air spaces that are distal to the terminal bronchioles, there is wall destruction but no fibrosis. Very easy. Understood each keyword, understood the factors and the causes, the different types. Okay. One of the complications of emphysema is pulmonary hypertension. Pulmonary hypertension because of many reasons. One of the main reasons is hypoxia that occurs. With hypoxia, what happens is the body tries to, in a way, counteract the hypoxia by causing vasoconstriction of my pulmonary arteries. It will try to vasodilate peripheral arterioles. When there's vasodilation in the peripheral, they will cause more blood flow that is going to be passing inside the pulmonary. And imagine there's more blood flow and it is already constricted. This is already going to be increasing pressure. Sometimes even the hypoxia will induce the kidneys to start to release something known as erythropoietin. If you remember, it is a hormone that is used to induce the process of erythrocytosis, which is the formation of my RBCs. RBCs, why are we doing this? Because RBCs have the hemoglobin, and if there's hemoglobin, which is going to be catching more oxygen. So the body tries to think that because I have hypoxia, let me just try to do this. But actually what it does is it might worsen it, because RBCs, they form the hematocrit, which is 45% of our blood. And imagine I have more erythrocytes. It makes our blood more viscous, and viscosity increases blood pressure, which can cause hypertension. Okay, so there are many different causes for hypertension. This is just a few of them, but you need to understand that pulmonary hypertension is one of the complications. There's another complication known as the cor pulmonale. Cor pulmonale is just the idea that there is right-sided heart failure that occurs due to this pulmonary hypertension. Why? And generally, it's very easy to understand. This is the heart. Sorry, just imagine as if it is. The right ventricle is supposed to pump deoxygenated blood to the pulmonary trunk in order to get oxygenated in the lungs, correct? If I have pulmonary hypertension, if my blood pressure is really high in the pulmonary trunk, the right ventricle won't be able to push past the valve, right? But the valve opens if here the blood pressure is much more. For now, the right ventricle will try to increase its own blood pressure by hypertrophying, and this is what causes right-sided heart failure. Okay? Because it's trying to push over because of this pulmonary hypertension. These are just the slides. This is the emphysema in patients. You can see the dilated air spaces and the thin septa here, right? And here, this is grossly, you will see the dilations. Clinical features are very important. These are words that you can look at and realize in the question that this is emphysema. In these patients, you will see hypoxemia with normal capnia. Where did we see this? Was it in hypoventilation or impaired diffusion? It was in impaired diffusion. It was an impaired diffusion. In these patients, in hypoxemia, they have hypoxemia. We explained the reason why. We explained how this happened, or why there is normal capnia and hypoxemia and impaired diffusion. But it makes sense, right? The alveoli here is damaged. The wall has been damaged. And I mentioned that impaired diffusion is in this specific area where there is damage to the wall. If there's damage to the wall and there is no longer, the surface area has been decreasing, right? And so the diffusion is impaired significantly. So diffusion is due to a defect because of the destruction of the alveolar walls, and the surface area for the gas exchange is completely destroyed. It's a problem. These patients have barrel-shaped chest because of the imagined dilation. This is the picture of it. So these are very important words that keywords you need to look out for. Barrel chest makes sense because I have dilations of the alveoli and the sinus region. So there's barrel chest. Patient will be dyspneic, as we mentioned, because there is normal capnia, and the respiratory center is working normally. And so you will see these patients are actively having difficulty in breathing. You will see that they are breathing heavily. They are taking very long time to breathe. You will see that there is pursed lip to try to increase the amount of air or ability to try to expire. You will be seeing them sitting forward to make it much easier as well for the breathing process. There is no cyanosis because, the respiratory center is working properly, and so it will counteract the hypoxemia through the dyspneic breathing style. So there's no cyanosis in these patients actually. Another keyword very important is pink buffers. Pink buffers. So these patients are having a great deal. They will expire and put a lot of exhaustion. They will be very exhausted because of how much effort they need to put in order to breathe properly. I like to learn it as pink buffers. Pink, just like the alveoli that we see, they're pink in color. So pink buffers. Buffer, you can think of the barrel chest, right? We can just try to link them in this way. So this was emphysema. Now chronic bronchitis is another, it is part of the COPD. COPD is just a combination of emphysema and chronic bronchitis. What is chronic bronchitis? In emphysema, my definition was purely structural. It was what the 3Ds, the dilation of the air spaces distal to the terminal bronchioles, wall destruction, no fibrosis. But in the chronic bronchitis, the definition is purely clinical. We can see that it is persistent cough, sputum production for at least 3 months and at least 2 consecutive years. These are important because when you see the case and you see these words, you will understand. The most important point for me is sputum production. Sputum as in mucus, as in المخاط العفو. Okay, the mucus production has increased. Why? Why has the mucus production increased? The mucus production increased because of irritants. So I have certain irritations. Mainly it is my smoking actually. COPD is very highly linked with smoking in general. So irritation is going to be causing mucus secretion to increase. With mucus secretion increasing, what happens? It's predisposing us or higher risk to infection. With infection, there is inflammation, right? The irritation is causing the mucus secretions to increase. What are the cells that are secreting the mucus? We have 2 types of cells. We have the submucosal cells as well as my goblet cells. So this is what we see. The pathogenesis, we have irritants such as the smoking, which cause the secretion of the mucus to increase, hypersecretion of mucus. These highlighted words are very important because these are the things that you need to note for. There is hypertrophy of my submucosal glands and hyperplasia of goblet cells. Hypertrophy, there is an increase in size. Hyperplasia, there is an increase in the number of the goblet cells. Goblet cells are supposed to be found in bronchi, but in bronchioles, you're not supposed to find them. And therefore, when you see goblet cells in bronchioles, due to this hyperplasia and increase in number, this is known as goblet cell metaplasia. Metaplasia, there is not supposed to be goblet cells in bronchioles, but in this case, you will see them, that they will grow. Also, you'll see inflammation sometimes and infiltration with lymphocytes, specifically my CD8, because of my inflammation. Whereas up in the emphysema, yes, I did mention the smoking and the irritation can cause a release of cytokines and inflammatory cells, but it was both CD8 and CD4. There is no specific one. Okay, so this is very important. Chronic bronchitis, main thing, mucus secretion is going to be very high because of hypersecretion of mucus and hypertrophy. How is this a problem? How is this? Well, it is a problem because of infections and everything, but how is this deemed as an obstructive disorder? Imagine there's a lot of mucus secretion. It starts to accumulate. It starts to cause thickening of the wall, and the lumen starts to destroy, get narrowed. So this is what we are seeing here, okay? Which is a problem. This is mucus causing thickening of the wall, but the lumen is very shallow. Now, the types of chronic bronchitis can be divided based on the mucus. In the emphysema, we divided based on the definition itself, which was dilation. So we looked at, when we divided the types of emphysema, we looked at where the dilation is happening. In the chronic bronchitis, the definition was persistent cough, sputum production for at least blah blah blah. For productive cough, or sputum production, we are going to be dividing the types of chronic bronchitis based on the type of the mucus. The simple chronic bronchitis, you have white mucus. It's just mucus in itself. Chronic mucus, purulent meaning I will have pus in it. So there is yellowish color of mucus. It is going to be involved with infection. Asthmatic bronchitis, where there is basically chronic bronchitis and patients have other manifestations of asthmatic signs such as wheezing or bronchospasm, and note it is intermediate because the asthma is coming in episodes. And chronic obstructive, well, this is the most severe case. It is both when the patient has emphysema as well as bronchitis, chronic bronchitis. The morphology, well, grossly we'll see that the bronchial wall is thickened, like we mentioned, and there is mucus inside of the lumen, and the mucous membrane will be inflamed, like we mentioned, because of the inflammation, of the accumulation of the mucus. These are signs of inflammation, swelling and hyperemia. Microscopy, again, hypertrophy of my mucus secreting, hypersecretion of mucus. There's something known as the Reed index. This is going to be a method in which we can measure the severity of chronic bronchitis. It is basically measuring the thickness of the mucus layer. So this is, let's say, the mucus secreting layer or gland layer, and then this is the thickness of the wall. So this is the read index. Generally, it is supposed to be 0.4. In chronic bronchitis, what was the problem was that there is hypertrophy of or hyperplasia of the cells that cause mucus secretion. So there's increase in the mucus secretion. So you'll find that the mucus gland layer had increased while the thickness is the same. And so the read index, what happened to it? It increased. So patients with chronic bronchitis, there is an increase in the read index over more than 0.4. And the more severe the chronic bronchitis is, the more read index is going to be increasing, because more thickness of the gland, mucus gland layer. This picture here just shows us you can see the whitish color. These are the mucus secreting glands. Again, this is what you need to look out for. The most important, I try to summarize: the hyperplasia of the mucus, there is wall thickening, and sometimes infiltration of inflammatory cells. Okay. Clinical features. Now, in this case, this was an obstructive obstructive, yani. And so because it was obstructive, what was the main thing that we noticed is that the patient will suffer from hypoventilation, obstructive hypoventilation. So in this patient, and we'll explain the reasons and what happens. We say there's hypoxemia and hypercapnia, because now it won't be able to leave us properly. It will enter, but it won't be leaving us properly. Hypoxemia and hypercapnia. Hypercapnia will depress my respiratory center, and therefore there is no signs of dyspnea. Patient will not have any breathing style that you will see in their fast or anything, or difficulty. We explained the pulmonary hypertension and pulmonary and cor pulmonale. There's central cyanosis in these patients. Because the respiratory center is blocked or depressed, it won't be able to do any steps or take any steps in order to counteract the hypoxemia. So patients will actually look cyanotic because of the decrease of the oxygen levels. And this is described as blue bloaters. Blue as in what? The cyanotic, you could think of it. So the emphysema was pink buffers. Pink was the color of, it's pink like the alveoli, and the buffer, we mentioned the barrel chest. As for the chronic bronchitis, no, it's blue bloaters, blue as in the central cyanosis, okay? The pathogenesis here again is being explained, which simplifies it. Now we go for the asthma. Asthma, it is chronic inflammation, and it is going to be periodic. This is very important. It's periodic. The asthma, it comes in periodic or episodic attacks, and there is bronchoconstriction, but it is reversible because of this periodic attacks. Okay, very important. We will notice that it is recurrent episodes of wheezing, of dyspnea, and cough. Again, it is a reversible. It is episodes, and usually the asthma is because of genetic reasons. We have many different types of asthma, but the main one we will see is because of genetic reasons, and you will see that there's infiltration of eosinophils and all of these things, and we will discuss them later. But in asthma, the bronchoconstriction is happening because of smooth muscle hypertrophy and increased mucus secretion. The smooth muscles will start to increase in size, and therefore they will cause bronchospasm, and they will constrict the heart. But it's only in reversible and periodic attacks, only when we look when. And there's increased mucus secretion. So the types I talked about. Atopic, it is the genetic one that I talked about. It will be found in childhood. There's a family history of allergic diseases, and these patients, very important, I wrote the most important type or things. It is a type 1. It is a hypersensitivity reaction. So they are sensitive to certain allergens, okay, which is causing these attacks. So whenever they encounter these allergens, they will cause these periodic attacks where there is the constriction of the bronchioles. What are these allergens? Usually it's exogenous, like pollens, the animal dander, the fur, all of these things. Also, we have positive skin test. The skin test is a test that is used to check what are you allergic to. And since this is an allergic reaction, a hypersensitivity reaction, they will have a positive test. In non-atopic, it has nothing to do with allergy. There is no hypersensitivity, but the patient is just going to be having, they're hyper-irritable to their bronchi. Yani it is very irritable to certain things, such as infection. It could be air pollutants like certain gases or smokes. It could be emotional stress, exercise, exposure to cold. Like in exposure to cold and exercise, there is dryness that happens to the mucus that is found in the bronchi, and this, when it dries, it can cause irritation. So here it is hyper-irritability, and obviously there is skin tests are negative since it's not related to allergies. There's also some certain type of drug-induced asthma, but they're more you could say, less common, and it could be because of aspirin or NSAIDs. And how is that? Because as we know, aspirin and NSAIDs, they block COX enzymes, and COX enzyme, as we remember, they work on arachidonic acid to convert them to prostaglandins and all of these things. But also we have other enzyme known as the LOX or the lipoxygenase, which also works on the arachidonic acid. In the aspirin or the NSAIDs, they block the COX, and therefore what ends up happening is the lipoxygenase will be working mainly on the arachidonic, since now the COX won't be able to work on arachidonic. What is mainly working is my lipoxygenase enzyme, and this means that there is more leukotriene. If the leukotriene increase, we know leukotrienes are going to be facilitating bronchospasm and increased mucus secretion, so there's even more of that. The morphology, well, it is going to be occluded with plugs of the thick mucus like we mentioned, and very important characteristics are two things I'll be discussing, which are the Crushman spirals and charcot leading crystals. The Crushman spirals are عبارة عن mucus plugs, and inside of it they are just going to be shed epithelium, okay, or desquamated epithelial cells inside of it. Whereas in charcot leading crystals, we mentioned how asthma is closely related with eosinophils, since it's a type 1 IgE, hypersensitivity, right? So sometimes in charcot leading, you'll see that charcot leading crystals which are eosinophils, and inside of them there's a specific protein known as the galactin 10. Sometimes there's also airway remodeling in certain more severe asthma attacks. These are very important because these are the things that you need to look out for. There's IgE production, there's T helper 2 cells formation, there's eosinophil involvement, inflammation as well. So these are the charcot leading crystals, which are what we mentioned. They are the eosinophils, and inside of it there's the galactin 10 protein. Whereas the Crushman spiral, it is the mucus that is going to be involved inside of it, the shed epithelium. Now we come for the bronchiectasis. Bronchiectasis, the definition, it is dilatation. Ectasis basically means أصلا dilation, and bronchi. So there's dilation of my bronchi. And where did we discuss dilation? In emphysema. Emphysema was also dilation, and the cause was that there is destruction of the wall and the elastin. So in the same way, there is also destruction of the elastic tissue and the wall, but the reason for it is different. In emphysema, there was two main reasons, which was smoking and the alpha-1 antitrypsin deficiency, but here the causes are different. This is the actual definition in the Robbins book. It says that it is disorder in which the destruction of smooth muscle and elastic tissue, and we'll look why. Why? It says by inflammation that is stemming from persistent or severe infections, leading to the permanent, again this is permanent and irreversible, dilation of my bronchi and bronchioles. So this is highly associated with infections. I have infections. So the main reason is infections. If I have a lot of infection, as we mentioned, there is going to be chronic inflammation. If there's inflammation, there's release of cytokines. These cytokines will be released and they will start to damage the elastin and destroy. The same method of the smoking. We mentioned smoking is an irritant which will cause the inflammation. But here the cause of the chronic inflammation in this case is infection, not irritation like smoking. No, it is infection. طيب, why do I have increase in infection? Either I have my environment is supporting infection, or it's just that my body can't handle or can't protect me from these infections. So I'm more susceptible to the infections because of my environment, or because of my body, it is immune system is not working properly. Where can I have my environment? In the lungs, I'm talking about. In the lungs, where can I have an environment that supports infections? It is mucus. If I have mucus, a lot of mucus there. Now, where will I see the mucus a lot? We will look at it. Now, predisposing factors, I can have congenital, meaning genetic factors, and could be the other. It doesn't have to be with genetic. The genetic one, we have cystic fibrosis. What is cystic fibrosis? And cystic fibrosis patients will have their mucus is very thick. The mucus is very thick. Why is my mucus thick in these patients? Normally I have this receptor that is used to, and this is some secretions, okay? Let's say this is my mucus secretions. It will pump chloride ions outside. Okay, it will pump chloride ions outside, and when it does this, this will pull water in. When water is pulled inside of a media or inside of a high, it makes it thin. It makes it more lubricant, right? In cystic fibrosis, what happens is that this pump is no longer working, or there's a mutation in the gene it's causing some problem, and it's not working properly, and therefore the chloride is no longer pumped. So there's decrease in the chloride inside of my secretions. If there's a decrease in chloride inside of my secretions, water also will no longer be absorbed, so there's less water inside my secretions. If there's less water, what happens to the mucus? It gets thick. So that's why mucus is thick. If the mucus is thick, why is that a problem? We mentioned this thick mucus is going to be predisposing us, or is going to be cultivating environment that is an environment that is very great for the bacteria to grow, you could say, which is going to be susceptible or causing us to be more susceptible to infections. And there's more infections, inflammation happens, and the whole cycle, we explained it. Another congenital disease, it is your genetic, it is Carter syndrome. In this patient, their cilia are not working properly. If we remember the cilia, these are, sometimes we have ciliated cells where they have these projections, these ciliated projections, and what they do is they are sweeping away the mucus. If in Carter syndrome, the cilia is not working properly, and so they're no longer sweeping the mucus, and the mucus starts to accumulate and accumulate and accumulate, and so this is what? Environment for bacteria, infections, okay? So more infections. So cilia is not going to be working properly. This is the congenital, genetic reasons. So we discussed where the mucus is. What if my body, now the body is not going to be responding properly to infections, or not responding, it is going to be highly susceptible to infections, like in immune deficiency states, like you're on immunodeficient drugs, immunosuppressive drugs, or if you're having HIV. All of these are going to be causing you to be more susceptible to infections. And when I have infections, I will have inflammation, chronic inflammation, releasing cytokines, destroying the wall. Therefore, there is going to be the key word is the infections. It's highly related with infections. Morphology, obviously the bronchioles are dilated and the lumen is going to be filled with my secretions. The wall will be thickened by the fibrosis because the elastin is no longer, the elastin is being replaced by fibrous tissue. Microscopically, again, dilation, destruction of the walls, and there is a very important dense infiltration of my chronic inflammatory cells. There is chronic inflammatory cells, inflammation, because of my infection that happened. Very important as well, you will see that there's foul smelling sputum. The sputum, the mucus itself is very foul smelling because of infection there, right? These are indicative of infection. Lastly, we come to the atelectasis. Ectasis was dilation. A meaning there is no dilation, is the opposite, there's collapse. Collapse of the lung. Why is the lung collapsed? Because of three different types. There's obstruction, compression, and contraction. Obstruction, let me explain it in this picture actually. In obstruction, or also called resorption, there's something that is obstructing the lung, and therefore there's no longer air that will get inside, and so the alveoli or the lung will start to collapse. Since the pressure here had decreased and the pressure here is different, there's a pressure difference here, but this collapses. No longer air is filling in because of an obstruction. It could be a foreign body, it could be of the obstructive diseases that we discussed, it could be many reasons, okay? So this is my obstruction. Prevents air from reaching, the alveoli will collapse. Another type is my compression. Here we're compressing the lung because something is compressing the lung. It could be fluid, like in what? Pleural effusion. It could be air, like what? Pneumothorax, right? So compression, there is something that is pushing or compressing the lung, and therefore it collapses because of these reasons. Accumulation, either fluid or air, like effusion or pneumothorax. The other type is a contraction. In this case, my lung had lost its elasticity and won't be able to expand properly. The reason is because it has been replaced by fibrous tissue. And so now, because it can't expand, it will start to collapse, just like we can see here. This is an irreversible reaction. At least here we can, for example, get the fluid out. Here we can treat the obstructive reason, for example, if it was a foreign or object or tumor, whatever. But here it's always irreversible because the elasticity has been gone, and it's been replaced by fibrous tissue, which is going to be preventing the expansion, and therefore it will start to collapse because less air. Okay, understood? So this is atelectasis, the collapse. These are also, by the way, all pictures from Robbins' book. This is going to be a summary for the whole thing that we discussed with the main important things. Anatomical size of chronic bronchitis, bronchi, so it is the bronchus. The cause was what? The cause was mostly my smoking, the irritant that caused mucus gland hyperplasia and hypersecretion. Remember? The signs, you will see the sputum production and cough. This was from the definition. persistent cough, sputum production, all of this, right? Bronchiectasis, remember this is the dilation of my bronchial bronchioles, this area, and there's dilation. Why? Because of infections. Remember, infections. In these patients, you will see sputum, blah, blah, but also you will see and purulent, meaning what? What? Infection, remember? And there's fever, which are signs of infection and inflammation and whatnot. Asthma, again, it is also the bronchus. There's smooth muscle hyperplasia, excess mucus and inflammation. This is because of immunological reasons, like we mentioned, or it could be undefined causes. We don't have one, it's just hyperirritability. And there is episodic, very important. It's periodic and episodic. It is a reversible again, wheezing, cough, and dyspnea, like we mentioned before. In emphysema, it was my sinus region. There's airspace enlargement or dilation because of wall destruction, mainly because of smoke. And the other reason was what? Alpha-1 antitrypsin deficiency. Which type of emphysema was that? It was the pan-acinar. And the main signs was dyspnea, and we discussed because it is impaired diffusion, and dyspnea is one of the signs of it. And we mentioned in the barrel chest and the pursed lips, and they will be sitting in a tripod position or hunched over. Thank you so much. I hope that you found this video useful and you understood and summarized everything. I tried my best to summarize all the points, the most important points, and explain each thing so that you will be able to understand, and when solving the questions it is much easier to understand it. Okay? If you have any questions, please let me know, and thank you very much.